2 to 3 important findings which is very most important in exam. One is the pulse, arterial pulse, another is the JVP, you have a second heart sound and a apex. So this 4 things determines your diagnosis. So JVP, arterial pulse, apex and the second heart sound. So most of the diagnosis is actually made by these 4 findings. So what is the arterial pulse? The arterial pulse is the palpability of a over the peripheral arteries, a pulse wave which is transmitted wave from the root of the aorta along the vessel wall, and it travels 10 times faster than the blood. So it is nothing but a blood which has come from LV ejection from the aorta to the vessel wall. There are both and it is the force which of the blood on the lateral wall of the blood vessels. So this is what is defined as the pulse. So we know that the blood travels at a speed of 0.5 meter per second. However, the pulse travels at a speed of 5 meters per second, 10 times faster than the speed of the blood, LV. So it mirrors the heart, and it is propagated by incompressible blood both forwards and laterally. So it is a lateral movement which distends the arterial wall and is felt as pulse. So pulse is the lateral movement of the blood column on the arterial wall. Now, what are the determinants of arterial pulse? So it can be divided into left ventricle. The most important is the stroke volume. So how do we define stroke volume? It is the product of the cardiac output and the heart rate. Then the LV contractility. So it is also affected by the poor LV function as in CCF, LV dysfunction, and the velocity of LV ejection. Apart from that, it is one more important determinant is the aortic valve, whether it is normal, stenotic, regurgitant, or both stenosis and regurgitation are there. And finally, the arterial system. How is the distensibility and the compliance and the elasticity of the arterial wall, and the peripheral vascular resistance. So it also depends on your systemic vascular resistance, whether it is high or low. And finally, the aortic runoff, which can vary in various conditions. So these are the various determinants of the arterial pulse. Now, this is one important diagram which represents many things. So from the left to the rightward, let's see. So this is actually a aortic tracing. So the upward aortic tracing, which is the pulse. So we know that the pulse has 3 parts. First is the percussion wave, and then is the tidal wave, and after that there is a dicrotic notch. So the upward wave is the percussion wave, and it is due to the LV ejection. So most of the wave is due to the blood is due to LV ejection, and which gives a percussion wave. And then comes the little downward wave, which is known as a tidal wave. So tidal wave is the pulse which is reflected from the upper extremities. So whatever recoil and whatever reflected wave come from the upper extremities, it is recorded as the tidal wave. And after the tidal wave, we get something known as the dicrotic notch. So this dicrotic notch has many importance. Once the aortic valve closes at the dicrotic notch. Second, it is the closure of the systole and the opening of the diastole. So the systole finishes at the dicrotic notch and the diastole starts at the dicrotic notch. And after the dicrotic notch, we get a dicrotic wave, and dicrotic wave is due to the reflected waves from the lower extremities. So the tidal wave is due to the reflected waves from the upper extremity, and the dicrotic wave is the reflected wave from the lower extremity. And dicrotic wave is also due to the elastic recoil of the aorta. When the aorta recoils, it produces a dicrotic wave. So, and the other pictures you can see the mean arterial pressure, and then you have a pulse pressure, which is the difference between the systolic and the diastolic blood pressure. Now this is one more important image which yesterday I discussed, the ECG and the jugular venous pressure. Here also the upper wave is you can see in the red is the aortic tracing. So the aortic tracing, you can see the systolic blood pressure, the aortic valve closes, that is the dicrotic notch, and then there is the LV tracing. You can see the LV tracing in the red, and the black tracing, the black tracing is the aortic tracing, and the red is the LV tracing. We know that the LV systolic pressure is almost same as the aortic systolic pressure in a normal person, whereas the LV, we don't have a LV diastolic pressure. We have something known as LV end diastolic pressure, which is normally 8 to 10 millimeter of mercury. So in cases of LV dysfunction, severe aortic stenosis and aortic regurgitation, the LV end diastolic pressure raises. Now again, coming to the various components of the pulse, We have something known as the percussion wave, which is due to the generation of LV ejection. When the LV ejects, it gives to the upper part of the pulse, which is known as the percussion wave. On the upstroke of the percussion wave, there is a anacrotic notch, which is usually not a palpable finding, but it is a phonocardiogram finding. It is usually aggravated or accentuated in patients with aortic stenosis, where there is a slow rising and late peaking pulse. So the anacrotic notch becomes more prominent. It occurs toward the end of the rapid ejection phase. So that is known as anacrotic notch. And after that, we get after percussion wave, tidal wave, which are the waves reflected from the upper part of the body, from the both the arms and from the head. And then we have something known as dicrotic notch, and then we get a dicrotic wave, which are the waves which are reflected from the lower part of the body, like the lower extremities and the other vessels. Apart from this, we have also something known as the incisura, which occurs in isovolumetric relaxation phase prior to the closure of the aortic valve. Now, there are two different types of pulse. There are central pulse and the peripheral pulse. The typical example of a central pulse is a carotid pulse, and the peripheral pulse are many, like the brachial, radial, abdominal, femoral, and there are many other pulses. Now, what is the characteristic of a central pulse is, it begins with the aortic valve opening and the onset of LV ejection. The rapid rising portion of the arterial pulse pressure curve is known as the anacrotic limb, which I already told you, and the anacrotic notch is frequently recorded on the ascending limb. It is usually a phonocardiographic finding and is usually accentuated in patients with aortic stenosis because we have a slow rising and a late peaking pulse. Also, the pulse has two systolic waves, that is the percussion wave and the tidal wave. The descending limb is less steeper than the ascending limb. We already saw that the ascending limb is very steep, fast upward slope, but the downward slope, the descending limb is less steep, and the descending limb is interrupted both by a incisura and by a dicrotic notch. As I already told you, the dicrotic wave is due to reflected waves from the distal arteries and by the elastic recoil of the aorta. So this thing is important. Now, how it is different from the peripheral pulses like the radial and the brachial. In the peripheral arteries like the radial and the brachial, the upstroke becomes steeper. It is more steeper and the amplitude is also very high. The systolic peak becomes very higher. The anacrotic notch disappears in the peripheral arteries and the systolic upstroke time becomes shorter. As I already told you, because it is more steeper, the time becomes shorter than the central arteries. This is the typical example of a central pulse. You can see the ascending limb is a little less steeper. The descending limb is also less steeper. There is a dicrotic notch. There is an anacrotic notch. As compared to the peripheral arteries, where a very steep ascending limb and the descending limb is also steeper as compared to the central arteries. Also, in the peripheral arteries, the dicrotic notch occurs much later and the systolic ejection time becomes more. So, the dicrotic notch occurs much later, systolic pressure increases, and the diastolic pressure and the mean pressure, it decreases in the peripheral arteries. So, the diastolic pressure in the mean pressure decreases in the peripheral arteries. Now, why there is so much difference in the central arteries and the peripheral arteries? There are a few mechanisms. One most important is the distortion and the damping of the pulse wave component. So there is a distortion and the damping of the pulse wave components. There is a different rate of transmission of various components. As we go periphery, the transmission is different. Also, the distensibility, the elasticity and the caliber of artery is very small as compared to the central arteries. And also there is a change in vessel due to the age and the disease process. So these are the various reasons why the peripheral arteries have a different shape and contour related compared with the central arteries. Now, which are the various peripheral accessible arteries? We know apart from the head, in the head and the neck, we have superficial, temporal, carotids, subclavian. In the upper limb, we have axillary, brachial and radial. In the abdomen, we have the abdominal aorta, which can also be palpable in the conditions such as atherosclerosis and the aneurysms of the abdominal aorta. In the lower limb, we have arteries like femoral, popliteal, posterior tibia and dorsalis pedis. I won't go into detail in the examination of these arteries because it is a topic by itself. But however, the few important points which is important in exam are the common carotid artery. It terminates at the C4 level at the upper border of thyroid cartilage. So at the upper border of thyroid cartilage, the common carotid artery terminates. It terminates into an external carotid and an internal carotid. The external carotid artery, though we usually don't palpate, it is palpated medial to the sternocleidomastoid above the upper border of thyroid cartilage. One important thing which you may be asked in exam is, where is the internal carotid artery palpated? So to palpate this, you have to place a hand in the mouth and palpate it against the tonsillar fosses. So this is one important point which may be asked in exam. How is it palpated? It is palpated in the mouth with a hand and the palpated on the tonsillar fosses. Now, where is the subclavian artery felt? It is felt in the posterior triangle. So you have to depress the shoulders and the pressure is exerted down and the back and medially in the angle between the sternocleidomastoid and the clavicle. Though not much important, if you don't know also it's okay, but it is just for your information that where can be subclavian artery palpated. We already know how is the brachial artery palpated, and axillary artery is palpable against the humerus. It is palpated by the compression against the humerus. Also the radial artery, which I don't want to go into detail, it is palpated using a 3-finger technique. Now, how do you explain a arterial pulse? This is the most important thing. When you explain a pulse, you should always tell rate, rhythm, volume, character, condition of the vessel wall, and the peripheral pulses. This 6 point everybody has to tell when you explain a pulse. So a rate of 76 per minute, regular, normal volume, normal character, the condition of vessel wall is normal, and all the peripheral pulses are felt. If not all, at least you should be able to feel the dorsalis pedis and posterior tibial, because the intact dorsalis pedis and posterior tibial may mean the other other pulses are also equally palpable or may be present. So at least the lower limb dorsalis pedis and posterior tibial you should feel. Also important is the vessel wall, which we do not go into detail. A vessel wall is usually palpated using 3 fingers on the radial artery, and you have to move your finger. You have to roll your finger on the radial artery. Sometimes you may be able to palpate the vessel wall, which is usually seen in Monkenberg's medial sclerosis. It is an arteriosclerotic condition where there is a calcification in the old age. It is known as the Monkenberg's medial arteriosclerosis. The character of the pulses we are going into detail now, and the other things I will discuss in the end after the character of the pulses. Now, is it important to grade the pulses? Sometimes you may have to grade the pulses, mainly in cases of peripheral vascular diseases. So a grade 0 means an absent pulse, 1+ means it is a feeble pulse, 2+ means it is palpable but it is diminished compared to the other side, 3+ is a normal pulse, and 4+ is a high volume or a bounding pulse. So these are the grading of the pulses. Now coming to the character of the pulse, we have almost 14 different characters. I will go into shorter detail into each of this, but I will discuss in detail the 3 to 4 important pulses of this. Now let's come one by one. So first important pulse is a pulsus parvus, which we typically call it as a pulsus parvus et tardus. Now it has parvus et tardus has 2 components. A parvus in Latin means a small or a low, and tardus means slow. So parvus means small and tardus means slow. So a small volume pulse or a slow rising pulse is known as a pulsus parvus, and it is typically seen in patients with aortic stenosis. Apart from severe heart failure, it is seen in patients with severe aortic stenosis, and it is typical of patients with severe aortic stenosis. It is a low volume pulse, and it is best appreciated in carotids, though can also be appreciated in peripheral arteries. It is a slow rising pulse. Now the second component of it is a pulsus tardus. Tardus in Latin actually means slow or late. So it is a late peaking. So late peaking is a tardus pulse. The peak is delayed and it is near to the S2, and it corresponds to a late peaking murmur. So in AS, if the murmur is late peaking, it means it is a severe aortic stenosis. It is best appreciated by simultaneous auscultation of the heart and the palpation of the carotid pulse. Now, I will go into little detail or later. From the apical, once the apical impulse is generated, it takes 30 milliseconds from the apical impulse to transmit to the carotid. So anything which is 30 milliseconds or less, we are not able to appreciate it. So what we have to do is we have to put a stethoscope on the apical, on the apex, and put your fingers over the carotid artery, and if you are able to feel any difference, it means there is a apicocarotid delay. So apicocarotid delay, if you are able to appreciate, it means there is a severe aortic stenosis, and it corresponds to the pulsus tardus, that is a late peaking pulse. It is usually seen in patients with a fixed obstruction to LVOT and not in dynamic obstruction like a hypertrophic cardiomyopathy. So it is a pathognomic of fixed obstruction like aortic stenosis, valvular. Now after the tardus, we have a third component, that is the anacrotic pulse. As I already told you, this anacrotic pulse is a important pulse in aortic stenosis. It is not a palpatory finding, it can only be felt by a phonocardiogram, and it is the accentuation of the anacrotic notch. Normally you get on the ascending limb of the pulse the anacrotic notch, and in patients with severe aortic stenosis, because of the delayed peaking, we get an anacrotic notch. So the typical characteristics are a slow upstroke, delayed peaking, and a small volume. As I already told you, parvus is a small volume, delayed peaking is tardus, and a slow upstroke, which is an anacrotic pulse. Apart from this, we also get a prominent anacrotic notch which appears earlier than a normal pulse, and the dicrotic notch usually disappears in cases of an anacrotic pulse. It is well felt in the carotids, and the earlier the anacrotic notch means severe is the AS. It correlates with a gradient between LV and aorta of 70 millimeter of mercury. So the earlier the anacrotic notch, more severe is the aortic stenosis. Now there are conditions where you can get a normal arterial pulse in patients with aortic stenosis, like if a patient doesn't have severe aortic stenosis and has only mild to moderate aortic stenosis, you get a normal pulse. If you have a significant AR, aortic regurgitation, then you may get a normal pulse. Sometimes aortic stenosis can mimic conditions like HCM. So HCM is a very close mimicker of which is a dynamic LVOTO. So it can have a normal pulse or it can have a jerky pulse, which I'll come in detail in further slides. Also, you can have a close differential, a supravalvular aortic stenosis and coarctation of aorta, where the pulse may be normal. You may get a murmur on the chest wall, you may get a BP, the difference and all. But the important is supravalvular AS and coarctation have a normal pulse. And in children and in too much elderly patient where the elasticity is lost and all, you can get a normal arterial pulse. Now, the next important pulse is a hypokinetic pulse or a low volume pulse. So I think you may be encountering in your day-to-day daily practices in patients with sepsis. Many patients who have sepsis, hypotension in the ICU, you may sometimes be getting a hypokinetic or a low volume pulse. But when it comes to cardiac condition, it can be because of low cardiac output, because of congestive cardiac failure or severe left ventricular dysfunction. Also in patients with LVOTO due to fixed or dynamic, that is aortic stenosis and hypertrophic cardiomyopathy also, you may get a hypokinetic pulse. Now in hypokinetic pulse, it may sometimes be you may be able to differentiate whether it is because of a low cardiac output, that is a decreased stroke volume, or it is because of the obstruction. So if the upstroke is normal, if you have a low volume with a normal upstroke, sometimes it is very difficult to, because the pulse has, I told you, two components, the upstroke and the volume. If you have a low volume but a normal upstroke, it means the stroke volume is reduced. However, if you have a low volume with slow uprise, it means there is a LVOTO obstruction. These are very typical bedside tips to diagnose and to know whether the hypokinetic pulse is because of LVOTO obstruction or because of the low cardiac output. Now after this, you may also be getting sometimes something known as a hyperkinetic pulse. I always want to tell you that don't confuse a hyperkinetic pulse with a collapsing pulse. See, a collapsing pulse is very different. It is a hyperkinetic pulse with a high high pulse pressure, whereas a hyperkinetic pulse with a normal blood pressure is usually a hyperkinetic pulse. So can be seen in a variety of conditions, as you may be knowing: anxiety, high cardiac output like anemia, pregnancy, also thyrotoxicosis, after exercise or a humid environment where the systemic vascular resistance decreases, after an intake of alcohol where the SVR decreases, cigarette smoking, and in patients with systemic hypertension with atherosclerosis or isolated systolic hypertension. So these are the various causes of a hyperkinetic pulse. Though not much important, you should know this type of pulse also. Now, one important thing is the hyperkinetic pulse has a larger than normal amplitude. So it is the amplitude which is different from a normal pulse, and it can result from three different mechanisms. Either the stroke volume is more, or arterial pressure is more, or LV ejection velocity. As I already told you, stroke volume is more because of SVR decreases in various conditions. Arterial pressure is more in cases of systemic hypertension and with atherosclerosis, and increased ejection velocity in various high output states like anemia, pregnancy, thyrotoxicosis, and others. So these three are different mechanisms which can produce a hyperkinetic pulse. Now let's go to the mechanism in just a short slide. So in elderly, we have atherosclerosis and a non-distensible arterial system, and that is what it produces the hyperkinetic pulse. In patients with anxiety and emotional excitability, the stroke volume increases. In high cardiac output, by both the stroke volume increases and the diastolic pressure is low. In the conditions with aortic runoff like aortic regurgitation and other, there is a low diastolic blood pressure and increased systolic blood pressure, increasing stroke volume. And the systemic hypertension produces a non-distensible arterial system. So these are the mechanism by which we get a high pulse volume. Now, in MR, in mitral regurgitation also, we get something known as a high hyperkinetic pulse, but it is not a collapsing pulse. It is a normal volume but a collapsing pulse. The volume is normal, the amplitude is high, but the pulse pressure is normal. So what is a mini? So what it is also known as mini collapsing pulse. I have written collapsing, but it is also known as mini collapsing pulse, which you can see in mitral regurgitation and also you can see in ventricular septal defect. So what happens is you have a normal volume, it is a jerky, that is the amplitude is high, but the pulse pressure is normal, unlike the aortic regurgitation where the high volume and high pulse pressure, which is also known as the collapsing pulse. So a severe MR with good LV function produces a mini collapsing pulse. If you get a Bispherians pulse in a MR, it means it is associated with hypertrophic cardiomyopathy. I'll come into detail about the Bispherians pulse. There is also something known as the Brokenberg sign. I don't want to go into detail, but you should also know what is a Brokenberg-Braunwald sign. It is found in patients with dynamic LVOTO, that is hypertrophic cardiomyopathy. Normally you get after a PVC, that is premature ventricular contraction. So after that, normally after a PVC, what should happen is there is a compensatory pause. In that compensatory pause, the LV filling occurs. So the LV diastolic volume increases. Now normally when the LV diastolic volume increases, the Frank-Starling law comes into play, which increases the arterial pulse pressure. So normally the arterial pulse pressure should increase after a PVC. However, in patients with hypertrophic cardiomyopathy, there is a paradox. Now what happens is after a PVC, the next beat there is a hypercontractility, which causes a dynamic LVOTO. Because of the hypercontractility, there is a LVOTO. Because of LVOTO, though the LV systolic pressure rises, because of the LVOTO, the aortic pulse pressure decreases. So in a normal patient after a PVC, the aortic pulse pressure should rise because of a Frank-Starling. But in patients with HCM, because after a PVC there is an increased contractility, which causes more SAM and obstruction, the aortic pulse pressure decreases, but the LV systolic pressure rises. Now because the LV systolic pressure rises, the aortic pressure remains the same. The gradient between the LV and the aorta increases at the expense of a decreased aortic pulse pressure. So this is known as the Brokenberg-Braunwald phenomena. In a MR, if you get a slow rising pulse, you should know that there is an associated aortic stenosis. If you get an alternance, it means there is a dilated cardiomyopathy which is causing MR, or MR is causing a myocarditis. So these are the two things which can happen with the alternance. In presence of MR with AF and all, you should see that there may be a rheumatic mitral regurgitation which is producing a AF. If in MR you get a slow, like a bradycardia, but a regular pulse, it can be due to a congenitally corrected transposition of great artery. It is a congenital heart disease which is known to produce AV blocks, complete heart block. And if you get an asymmetry of pulse, it means there may be a infective endocarditis producing a systemic embolism. So these are the various meanings of an arterial pulse in a patient with mitral regurgitation. Now let's go to next important pulse, which is a jerky pulse. Now what is a jerky pulse? I just now described a mini collapsing. A mini collapsing is a high amplitude pulse with a normal volume, normal pulse pressure seen in mitral regurgitation. However, in patients with hypertrophic cardiomyopathy, there is a jerky pulse where is a brisk or a sharp upstroke. The upstroke is sharper as compared to a normal pulse, and it literally taps your palpating finger. The pulse volume is not increased, the pulse pressure is not increased. So a rapid upstroke, normal downstroke with a normal volume, normal pulse pressure is known as a jerky pulse. It is typically seen in hypertrophic cardiomyopathy, can be palpated best at the carotids. If you feel for carotids, you can feel for a jerky pulse apart from a bispherians, which is a pathognomic or not pathognomic, seen in most of the patients with a severe hypertrophic cardiomyopathy. Now, coming to the collapsing pulse, I would like to stop for 1 minute. If any doubts are there, you can, because I have too many slides, around 70 to 80, so I would like to interrupt in between. If Sanket is not there, if anybody is there, they can mute themselves and can ask the doubt.
Yeah, I'm there, sir. I'm attending.
Yeah. Otherwise, I'll proceed in next 10 seconds. Yeah.
I think
I wanted to go slow because there are too many pulses which are there.
Yes, it's actually a huge topic and very importantly asked sometime the Viva, total Viva ends here.
Yeah.
So I think one very important point what you tell for the carotid palpations, that we have to palpate inside, and that also it is important to carry a gloves in the exam. So for cardio case, specifically some old examiner expect that your gloves should be there, then only you can palpate that pulse, otherwise you cannot palpate. Second very important point, like it is common sense, but both the carotid should never ever be palpated together. Because that is something that is they give you 6 months more for that. So these are the two things I think I heard and I would like to add. Otherwise, I think, sir, if doubts are there, it will come to my mobile also.
Yeah.
I will ask you and we'll continue, sir. And in between, this kind of breaks will be fine. If students require more break, you can message me. I can tell sir to take a break also. It's completely fine. It's a huge topic, but I think all slides are your Viva only. So one by one, we'll go ahead.
Right. Now, next important pulse is a collapsing or a water hammer pulse. Now, this is the most important pulse. I think one of the first important pulse which you should know how to demonstrate, because I feel there are two school of thought there. Many people palpate in a different way, but a typical how the collapsing pulse should be demonstrated is different. I have forgotten to put the video of that, but I will share today in the group. I'll give it to Sanket. But the collapsing pulse was actually told by Thomas Watson, and it was named after a Victorian toy. So if you have seen a Victorian toy, you will know why it is known as the water hammer pulse. Now, how do you palpate it? I'll just tell it theoretically. With your left hand, you feel for the pulse of the patient. The first important thing is you should get a high amplitude pulse. So large volume pulse is the first prerequisite of a collapsing pulse. If you are not getting a high volume pulse, then there is no point of demonstrating a collapsing pulse. So once you get a high volume pulse, you should go more proximally and keep on palpating the radials till you do not feel the pulse. Go more proximally till you do not feel the pulse, and then once you do not feel the pulse, make a fist around the hand. And then with your right hand, suddenly raise the hand of the patient above the head. Raise the hand of the patient above the hand. What will this causes? This causes the artery to come in the straight line with the central aorta. So once this happens, once the artery comes in the straight line with the central aorta, there is a runoff. So this is the first mechanism of the collapsing pulse. Why does it collapse? Because there is a diastolic runoff into the left ventricle, because the aorta, central aorta, is in a straight line now with the hand. Now what happens in next, once the LV fills with the blood, it produces a larger ejection fraction, so it contracts more. Once it contracts, it activates the baroreceptor, carotid baroreceptors, which causes a reflex vasodilation. Now this vasodilation is again responsible for the collapsing pulse. So in a patient with aortic regurgitation, there are two major mechanisms of collapsing pulse. One is central, another is peripheral. Peripheral is caused by this mechanism. When you raise the hand comes in the straight line with the central aorta, blood goes to the LV, and there is a diastolic runoff. The central mechanism is, once the LV fills with the blood, the LV contracts, it activates the carotid baroreceptors, which causes a reflex vasodilatation and causes a runoff. And third, sometimes there is a rapid runoff from the periphery due to decreased SVR, which is I already discussed this. So these are the mechanism causing a runoff. Now what do you appreciate in the hand? Once you make a fist and the hand is raised above the head, you can feel the pulsations from the ulnar, across the ulnar, because now the blood is now filled via the ulnar and comes down. So you can feel the pulsations over the ulnar artery. So that is how you feel for a collapsing pulse. Feel for the radial pulse, a good volume pulse should be there. Go more proximally till radial is not felt. Make a fist around the hand, and with the right hand suddenly raise the patient hand over the head. You will start feeling for the pulses over the ulnar part of your fist. So that means you have a collapsing pulse. So this is why a collapsing pulse is important. This is the mechanism of a collapsing pulse, and this is how you have to demonstrate a collapsing pulse. Now what are the causes of the collapsing pulse? Now they are divided into three major types. The most important is, I think all of you will be remembering only two causes, most of you at MD level: aortic regurgitation and a patent ductus arteriosus. Now why this is important is, in aortic regurgitation you get a collapsing pulse because of a high pulse pressure, because your aortic systolic pressure is 150, aortic diastolic pressure is 50 almost. So with a 100 mm of pulse pressure, you will have to get a aortic runoff. In a PDA also similar thing happens, but your aortic diastolic pressure does not go that much down. Other causes of aortic runoff is AP window, from aorta to the pulmonary there is a runoff. Rupture of sinus of Valsalva, where all the aortic blood goes off to the RA and RV. So if a RSOV to RA and RV causes a runoff and collapsing pulse, and the AV fistulas, various AV fistulas can cause runoff. When you encounter a patient with a cyanotic heart disease and you find a collapsing pulse, it means the patient may have a truncus arteriosus. Second, you may also see in a patient with tetralogy of Fallot with their collaterals, or tetralogy of Fallot with aortic regurgitation, or with a patent ductus arteriosus, or sometimes after a BT shunt. And you may also see it in patients with pulmonary atresia with AP collaterals. I don't want to confuse you. Remember the major causes: aortic regurgitation, patent ductus arteriosus, and RSOV. So these are the major causes. Now sometimes you may feel for a collapse. You may get a collapsing pulse. It is not a true collapsing, but it is a high volume with a near collapsing. You can see in 5 typical hyperkinetic states like anemia, thyrotoxicosis, pregnancy, alcohol causing beriberi, and fever also. High hyperdynamic circulation in fever, and Paget's disease of the bone. So this can also produce hyperkinetic states. And sometimes, as I already told you, mini collapsing pulse. It's not a true collapsing because the volume is normal, pulse pressure is normal, only the amplitude is more. So it is seen in mitral regurgitation and ventricular septal defect. So these are the causes of collapsing pulse. I have already discussed this. I don't want to go into detail. The various peripheral signs of aortic regurgitation, which I have discussed 2 classes back. Now let's come to the second most important pulses, Bispherians pulse. Now there are 3 types of pulse which have a double peak or double peaking pulse. They are known as double peaking pulse, or twice double so the double peaking pulse are anacrotic pulse, dicrotic pulse, and Bispherians pulse. Now the difference is a Bispherians pulse has both the peaks in systole, because you have a higher percussion wave, and wherever you find a prominent percussion wave, your tidal wave also becomes prominent. So we all know tidal wave is a part of systole. So both the tidal wave and the percussion wave becomes prominent. Whereas in a patient with a dicrotic pulse, you get one peak in systole and the other peak in diastole. The other peak is the dicrotic wave, which is reflected from the lower extremity and because of the recoil of the aorta. So the basic difference is Bispherians pulse has both two peaks in systole, and the dicrotic pulse has one peak in systole and other peak in diastole. Now, why do you get Bispherians pulses? I don't want to confuse it with the first slide. Let's go to this. Now, can you see two peaks? You can see the first peak is percussion wave, second peak is tidal wave, and then you have a dicrotic notch and dicrotic wave. But these two peaks are important. Now there are two important causes of a Bispherians pulse. The first pulse important is hypertrophic cardiomyopathy, where there is spike and dome. So the first peak is called spike and the second peak is called the dome. Now why you get a first peak? Because 70% of the blood is ejected from the LV. So that 70% causes a high amplitude here. And after that you get the systolic anterior motion of the mitral valve. Now you know in HCM there is a systolic anterior motion of the mitral valve. When the SAM occurs, there is a halt or there is a stop to the progression of the blood, which causes a downward movement. And then once the SAM goes off, the 30% of the blood which is left is again ejected by the LV. So you get the tidal wave. So the typical is in HCM, in a Bispherians pulse, the first peak is always more than the second peak, and the second peak occurs later. There is a duration. Whereas in aortic regurgitation, the second peak is of the same height, or it can be higher than the first peak, but never it can be lower than the first peak, and it occurs earlier. The second peak occurs earlier than the first peak. So these are the two important difference. Now I already told you the mechanism of Bispherians pulse in hypertrophic cardiomyopathy. Now why does it happen in patients with severe aortic regurgitation is, now the first blood is ejected from the LV into the aorta. So you get a first peak. Now what happens is all the waves are reflected from the periphery. So from the upper extremities, the reflected wave causes the second peak. Because there is aortic regurgitation, the aortic valve is not yet closed. So whatever blood has pumped by the LV, it is reflected from the upper extremities, and the same volume of blood, or sometimes the more volume of blood. And that is why the second peak is usually same amplitude or higher amplitude compared to the first peak, and it occurs earlier as compared to the hypertrophic cardiomyopathy. I think I have made it clear. But there is third cause also, which is the significant aortic regurgitation with mild to moderate aortic stenosis. So in patients with a combined AS and AR, the AR should be severe and the AS should be mild to moderate. Now this mechanism is not largely accepted, but what they tell is the stenotic component permits a jet. So because of that, they're lateral to the jet, there is a fall in pressure due to the Bernoulli's phenomenon, and this results in the dip or the inward movement in the pulse, and then there is a second outward movement in the pulse, which is a tidal wave. So AS-AR produces this finding, and that is why it produces a Bispherians pulse. I think if you remember the mechanism of Bispherians in HCM and AR, it is more than enough, and this is what I have already discussed the mechanism. So spike and dome is seen in HCM. Now let's come to the second double peaking pulse, which is a dicrotic pulse. I think this is one important pulse which more than us you will be seeing in medicine in your patients with sepsis, because one of the most important mechanism of a dicrotic pulse is a sepsis. Now in what happens in a dicrotic pulse, you get two peaks, but one peak is in systole and other peak is in diastole. It is called a twice beating pulse, and you need two important things. One is the most important pathognomic is the elasticity of the peripheral arteries, which should be normal. Unless the elasticity is normal, you do not get a dicrotic pulse. That is why you do not get dicrotic pulse in people who are older than 50 years, where the elasticity is lost. Also, the patient should have hypotension, like in patient with sepsis and typhoid fever. They have hypotension, and the peripheral vascular resistance should be reduced. Like in sepsis, we know the SVR reduces. So that is why we get a dicrotic pulse. The first peak is because of the LV ejection. The tidal wave is not there, or it is diminished. Then we get a dicrotic wave because of the elasticity and the reduced PVR. All the waves are reflected from the lower extremities or a peripheral arteries, and that is why you get the second peak, that is the dicrotic pulse. And when the reflection wave travels rapidly and meets the original wave well in advance, it is lost in it. And the one of the important thing in patient with rigid system, like more than 50 years in systemic hypertension, the dicrotic wave is never present, because it is always seen in patient with the elastic vessels. And it should be differentiated from a Bispherians pulse by the simultaneous auscultation of the heart sounds. So this is one important thing about the dicrotic pulse. There are few other in a cardiology, we see dicrotic pulse when the patient is on IABP, intra-aortic balloon pump. So intra-aortic balloon pump, we get an augmented wave. Why? Because of a diastolic flow occlusion. Because the IABP, the balloon is inflated during the diastole, we get a diastolic flow occlusion and an augmented wave, which is known as a dicrotic wave. So one of the important wave you may get in some of the spotters of a IABP picture, and you will see a double beating pulse, one in systole, one in diastole. It may be because of the IABP. So it is rarely present dicrotic pulse when the BP is more than 130 and when the patient is above 50 years of age. It is also appreciated better after a premature ventricular contraction. So you get a dicrotic wave sometimes in healthy young adults who have a lower systemic vascular resistance, after a fever, hypovolemic shock, sepsis, where the systemic vascular resistance decreases. Rarely you can still find in patients with CCF, because in CCF usually the SVR is high, and in cardiac tamponade, also following a IABP and post AVR, you may find a dicrotic pulse. You can remember few causes like sepsis, low cardiac output, and IABP, which will be more than beneficial for you. Now again, I will tell you twice beating pulse. There are three types: anacrotic, Bispherians, and dicrotic. How do you differentiate? The double peaking occurs on the upstroke in anacrotic. As I already told you, on the upstroke in anacrotic is not actually a true twice beating pulse, where so it is a late peaking. On the peak, it occurs on the peak in Bispherians. So the double peaking occurs on the peak in Bispherians, but both are in systole, and it is a rapid rising. Whereas a dicrotic pulse, it is on the downstroke. The double peaking occurs in the downstroke, and it is a normal rising pulse, one in systole and one is diastole. So if you remember these three things, it will be useful. Now let's go. I would again like to interrupt for again 10 seconds. I want to go slow, and I want people to ask doubt, because if they are not asking, I think there is some more confusion. So if you have one or a few doubts, you can just ask. Otherwise, I'll just interrupt for some few seconds. Sanket, if you also have any question, you can just ask, so we can make it more discussion.
Sure. Yeah, so I think these topics are in a way day-to-day basis we discuss. So if any doubt or something is there, definitely you can put a message to me, and I can get it to sir, because these are the topics we discuss daily, and some common mistakes are there. So if something is there, please ask your doubts.
So now, after the collapsing or a water hammer pulse, the second most important pulse, which is also asked too much in an exam, is a pulsus paradoxus. Now, pulsus paradoxus is some important pulse, and there is a paradox. Now, why it is a paradox is, I think where somebody may ask you, and many of you will know, the paradox is the pulse is absence of pulse during inspiration, but the heart sounds are preserved at that time. So when you auscultate the heart, you are able to hear the heart sound, but when you are palpating, you are not getting the pulse. So that is what is the paradox in pulsus paradoxus. It was coined by Adolphe Kussmaul, the same Kussmaul who gave Kussmaul's sign, which we already discussed yesterday. When do you suspect a paradox? It is suspected if the pulse varies with inspiration in all the accessible arteries. You feel for the pulse, but the pulse is varying with inspiration and expiration. It means there can be underlying mechanism of a paradox. Also, when we see a monitor on the screen, you can see the pulse waveforms. The pulse waveforms on inspiration and expiration, there is too much variation. So if a patient in ICU, a patient with shock, you are seeing too much of a variation, you should always suspect paradox. Not only the pulse wave, saturation waveform, you can also see the BP waveform. Even a BP waveform will vary with inspiration and expiration. In a shock patient in ICU, you should always suspect that some paradox may be there. Now, why it is a misnomer? The term paradox is that normally there is a fall. So what happens on inspiration? There is an increase in the blood on the right side, but there is a decrease in the blood on the left side. Why there is a decrease blood to the left side is on inspiration, all the blood is pulled towards the pulmonary vascular blood. So much of the blood doesn't go to the LA, and that is why there is an inspiratory fall in systolic blood pressure. Now, normally the inspiratory fall is around 4 to 6. But if this is aggravated on inspiration, if you get more than 10 millimeter of mercury drop on inspiration, it is a paradoxus. So normally during inspiration, the blood pressure falls of around 4 to 6 as compared to expiration. However, if this drop is more than 10, it is known as paradoxus. If the drop is more than 15, it is known as a severe paradoxus. Now, there are various mechanisms. I don't want to confuse you with many mechanisms. The cardiac mechanisms are 2 to 3. The most important cardiac mechanism is cardiac tamponade. Apart from constrictive pericarditis, cardiac tamponade is one more. So what mechanism is there in cardiac tamponade is, in cardiac tamponade, yesterday I already told you, people who have attended or have listened to the recording, what happens is both the early part of the diastole and the later part of the diastole is hampered. So because there is a tamponade, there is a fluid in the pericardial space, and that is why the filling of the LV during the LA and the LV or RA and the RV during the diastole is hampered. Now, because of this, there is once the filling occurs in the RV, it shifts the interventricular septum towards the left side. So what happens is, there is a leftward shift of interventricular septum, which causes a decreased LV volume and diastolic compliance. Now, because of this, there is a paradox. So what happens in tamponade is, RA volume increases, there is a movement of the interventricular septum towards the left side, which causes decreased LV volume and LA volume, and hence you get an inspiratory fall in systolic blood pressure. This is the mechanism which is important in cardiac tamponade. Now, many people will ask, why does it happen in constrictive pericarditis? Now, in constrictive pericarditis, there is a constriction to the intracardiac structures. Now, in constrictive pericarditis, we know LA, which is an intrapericardial structure, but the pulmonary veins are extrapericardial structure. The pulmonary veins are not in the intrapericardial. Now, what happens is, when the elevated intrapericardial pressure happens, the pulmonary veins, which is extrapericardial, there is increased blood flow to the pulmonary vein. But LA, which is intrapericardial, the flow doesn't grow from the pulmonary vein to the LA because of the constriction, and that is why there is a fall in LV cardiac output. And the LA pulmonary vein to LA gradient is less. The blood doesn't grow from a pulmonary vein to LA and LA to LV, and that is why in constrictive pericarditis you get a significant systolic decrease in blood pressure. I hope I am clear. I again repeat. In constrictive pericarditis, we know there is a constriction. So when the elevated intrapericardial pressure is there, it is transmitted to the pulmonary vein but not transmitted to the LA because it is a intrapericardial structure, and that is why there is a gradient which is decreased from the LA to the pulmonary vein to the LA, and the blood doesn't go to the LV. Now, they will again ask you, why does paradox happen in cardiac cause, in non-cardiac causes like severe COPD, bronchial asthma? Now, the mechanism is different. What happens is, on inspiration, in this produces, because the intrathoracic pressure is very high, all the blood is pulled towards the pulmonary vascular bed. You know, because they're in COPD and severe bronchial asthma, there is high intrathoracic pressures which causes the pulling of the blood towards the pulmonary bed. So all the blood from the LA is diverted to the pulmonary bed, and that is why LA and LV filling are less, and that is why you get a paradoxus in COPD and bronchial asthma. Now these are the major mechanisms. This image tells you very clearly. On my right side you can see normal respiratory variation which is less than 10. On my left side you see a paradoxical respiratory. On systole there is a more than 10 mmHg fall in BP. Now most important point, I am telling you paradox, but we are not able to appreciate a paradox. See, few bedside findings are, you feel auscultate, you get a good heart sound, but you are not able to feel the pulse. That is one important thing, is you are able to feel the paradox. So palpatory paradox is present only when the paradox is more than 15 mmHg. If it is less than 15 mmHg, you are not able to feel a palpatory paradox. Then you should always see the monitor, your saturation tracing, how does it vary with inspiration and expiration. Most importantly, you have to use a sphygmomanometer to demonstrate a pulsus paradox. So how do you demonstrate? Now you have to inflate the BP above the systolic blood pressure. First, patient should be told to breathe quiet. It should not be able to breathe heavily. You should be sitting in a quiet environment, not in a loudy room. You raise the systolic blood pressure above the systolic blood pressure, the cuff, and then start deflating it very slowly. Normally we deflate it at the rate of 2 mm of Hg per second. You try to deflate it more slower than that, because it is a 10 mm Hg which you have to feel. Now the difference of the systolic pressure at which the sounds are first heard only during expiration. Now once you start deflating, you will able to feel the carotid sounds only during expiration, and then once you start deflating it further, you are able to hear it both during inspiration and expiration. So first only one sound will come, like tuck, 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 and when you further decrease it, you are able to hear it both during inspiration and that is double sound, tuck, 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 tuck. So this is the point at which you have to stop, and the difference is the paradox. So the difference when the sounds are heard only during expiration and then later during inspiration and expiration is a measure of the magnitude of paradoxes. So if it is more than 10, it is a definite paradoxes. Now, as I already told you, there may be physiological causes which are not much important, like massive obesity or a pregnancy. Respiratory causes are severe COPD, bronchial asthma, emphysema, and a large severe bilateral pleural effusion may rarely produce a paradoxus. But the most important thing is cardiac causes. Now in cardiac causes, if you remember 2 causes, it is more than enough. That is a cardiac tamponade, which by far is the most important cause of tamponade. However, only 1/3 of the patients with constrictive pericarditis have paradoxus, which should not be told at the first place. Rarely in patients with massive pulmonary embolism, because all the blood is diverted towards the pulmonary vascular bed, you may get a. And also the second important mechanism is a REV dilatation, which shifts the septum towards the left side. So LV cardiac output reduces, and so is true with SVC obstructions and all. Now, what determines the pulsus paradoxus is the venous return, and that is the preload, and then the LV afterload, and the diastolic ventricular interdependence. I told you at first place the most important mechanism in tamponade is the reverse Burnham, that is the septum is shifted towards the left side, and the lung volume. And how good are the intrathoracic pressure? How are the lung volume? Because in constrictive, in COPD and all, the major mechanism is the blood flow towards the lung, which causes a decreased LA and LV filling, and the circulatory reflexes. So the principal determinant is the underfilling of the LV during inspiration in relation to the RV. So that is the principal determinant of a pulsus paradoxus. Now, sometimes you may get a tamponade without a paradoxus. These are the few causes. I think if you know 1 or 2, it is important. Many times they may ask you for a gold medal, what is the causes of tamponade without paradoxus. In patients with severe left ventricular, right ventricular hypertrophy, in patients with a pulmonary hypertension which causes a raised RA pressures, and in patients with atrial septal and ventricular septal defect or aortic regurgitation. So these are the causes where you get a tamponade without paradoxus. And why is this? Because there is a lack of competitive ventricular filling during inspiration. Normally during inspiration the LV filling is reduced. Now these are the cases which doesn't allow you to cause a decreased LV filling. We know in ASD you have a shunt from the left to right, and VSD has a shunt from left to right, and then AR which produces a diastolic runoff which may increase the effective forward cardiac output. And so these are the mechanism which cause a tamponade without a pulsus paradoxus. Now a word on a rare thing which is a reverse paradoxus, that is normally in inspiration if the systemic blood pressure rises. So normally if there is an increase in inspiration, the systolic blood pressure usually decreases. However, if there is a paradox rise in systolic blood pressure with inspiration, it is known as a reverse pulsus paradoxus. And why does it happen is there are three mechanisms. That one is a hypertrophic obstructive cardiomyopathy, which has an unknown mechanism, isorhythmic AV dissociation, and the third important where they have actual causes, intermittent positive pressure ventilation. We all know in patients who are ventilated, mechanically ventilated, the intrathoracic pressure is higher during inspiration, and so the blood comes more into the LA and the LV as compared the reverse of the paradoxus or a COPD and bronchial asthma, where it is the reverse one. So this is what happens in a reverse pulsus paradoxus. Now let's go to the next important pulse, which is a pulsus alternans. Now this is one pulse which you will be seeing in patients with CCF, severe LV dysfunction, heart failure, or rarely in aortic stenosis patients who have LV failure. So what happens is they beat at regular interval, but in which there is a regular attenuation. So for the first peak may be more, the second peak may be less, one more, one less. So this is what is pulsus alternans. It is a manifestation of the LV failure. So there are two components. The first component is alteration in the height of the pulse. Second is the rate of the rise. The height of the pulse you may not be able to appreciate. You may be able to appreciate only the rate of the rise. So first pulse may be high, early rising, then slow rising, early rising, low rising. So you may be able, that is what the alternance is, and it is the rate of rise which is appreciated during the palpation, and it is palpated more better in the distal vessels than the proximal. That is in the you can feel it more better in the radial arteries than the carotids or the brachial arteries. And also you should always palpate it with a lighter finger, with a light pressure applied over the fingers. Now again, the sphygmomanometer has a very important role in telling the pulsus alternans. How do you do it is inflate the BP cuff above the systolic blood pressure and then slowly deflate it unless the carotid curve comes audible. Now first initially this carotid curve sounds and the beats are heard at half. You have to see how much the heart rate is. Now initially they are only heard at half of the heart rate. If the heart rate is 100, you are only feeling 50 times the sound. When you further deflate the cuff, you can feel that the carotid curve sounds, the rate doubles. So the rate doubles so initially when you deflate the cuff, the carotid curve sounds are audible at half the heart rate, that is example 50. Further deflating the cuff, you can feel all the carotid curve sound, that is the 100, all the 100 beats. So this is how you appreciate a pulsus alternans. Now it is due to the alteration of the contractile system of the myocardium, where there is a defect in the calcium coupling. So the calcium, because of the heart failure, LV dysfunction, the electromechanical coupling doesn't happen, and so there is a weaker contraction when you have a during the heart failure, not the fixed volume of the blood occurs to the LV. So when the good volume occurs, the LV, the end diastolic volume is more, so the coupling is good. When the less volume occurs, the coupling is poor. So the calcium has an important role to play in the pulsus alternans. So this is what is important. Now how to look for alternans? I already told you it should have a regular heart rate. Peripheral arteries like the brachial and all you should feel. Light pressure should be applied. Breath should be held in end expiration or a mid expiration. And it is brought over, means you can appreciate it by certain maneuvers like sitting, by decreasing the venous return like standing, or head up tilting like a tread and Lundberg position. And most of the time at alternance is always associated with a S3. Now there are some maneuvers like a premature ventricular contraction or atrial pacing or a myocardial ischemia. During that your alternance is induced. Now the causes are various, you know the basic of it: LV failure of any cause, myocarditis, dilated cardiomyopathy, acute pulmonary embolism by not only reducing the RV ejection but by decreasing the LV ejection fraction, severe aortic stenosis and severe pulmonary stenosis with heart failure, and severe AR, especially following aortic valve replacement. So these are the various causes of pulses alternance. I don't want to tell each of them individually because the basic mechanism is same. Now, one important question they may ask you is, how do you differentiate it from a bigeminy? Now, you know, in bigeminy, in pulses alternance, LVS3 is there. In pulses alternance, the interval between the weak and strong beats are equal. You know, in a bigeminy, after a weak pulse, you get a compensatory pause, and after that compensatory pause, the next pulse will be a high volume. So the difference is between the two, sometimes the two pulses the double of the previous beat, and that is how you differentiate a pulses bigeminy, because of the compensatory pause from the pulses alternance. Now this images are there, which I don't think so is much important at present. Now this was what I was telling you in the beginning. What was the time taken from the aortic pulse to reach the carotid? It is 30 milliseconds. That is why if you see a picocarotid delay, if you are able to appreciate, it means it is a severe aortic stenosis. It means the murmur is late peaking. It means the pulsus parvus et tardus is there. So anything which is 30 milliseconds or less is cannot be appreciated by the human ears. However, if you are able to appreciate, means it is more than 30 milliseconds, means a picocarotid delay is there. After carotid, the aortic pulse reaches the brachials. It takes 60 milliseconds. And it takes to radial is 80 milliseconds. However, it reaches faster to the femoral than the radial. It reaches femoral in about 75 milliseconds. Now, why is this important is, many a times we tell radio-radial delay, radio-femoral delay. If you see, if to appreciate a radio-femoral delay, it is very difficult because the time difference is 80 minus 75, that is only 5 milliseconds, which cannot be appreciated by us. But a brachiofemoral, if you see, it is 75 minus 60, that is 15 milliseconds, which is still okay. But in a radio or a brachiofemoral delay, it is not the time period which is important. It is the rate of rise of the pulse which is important. So this brings us to the next important thing in pulse, which is the radiofemoral delay. It is not the delayed arrival of the femoral pulse wave, but instead a slow rate of rise to a delayed peak. I think this is important. I always tell my student, it is not the arrival of the pulse, but the rate of rise to a delayed peak is more important in a radiofemoral delay. So that is what is more important. Now, what is the cause of radiofemoral delay? The first and the foremost and the pathognomic cause is a coarctation of aorta. So the coarctation of aorta, if the coarctation is pre-subclavian, you get a radiofemoral delay. Or any occlusive or aortoarteritis or atherosclerosis diseases, that the bifurcation of the aorta, common iliac artery or the external iliac artery, it causes a radiofemoral delay. Now, next important thing is a pulse deficit. Now, many a time when you tell the pulse is 100 per minute irregular. When you tell irregular, there are many things which should come to your mind, that what are the causes of a irregular pulse. So, three important differential of irregular pulse is atrial fibrillation, then premature ventricular contraction, then a atrial flutter with a varying block, and then sometimes we can have a multifocal atrial tachycardia. So these are the four common differentials of an irregular pulse. Now, can you differentiate these pulses? AF can sometimes be differentiated from a VPCs. How? In AF, you get something known as the apex pulse deficit. Now, to appreciate apex pulse deficit, you need two people. One person has to feel for the apex beat, and another person has to feel for the pulse beat. So if the difference is more than 10, it is known as the apex pulse deficit. You can also do with a single examiner. How can you do it? One, you feel for the apex and feel for the pulse, and you see the number of discrepancies between the two. If the number of discrepancies are more than 10, it means an apex pulse deficit. But it is always ideal if you are able to do it like that. So but never do with a single person at different time. This is one important message which I want to take is, don't do it at a different time. Don't look at the pulse at once and then the apex at once. Why? Because these are the different timing cycles, the different cardiac cycles where the things may vary. So at the same time you may have to feel both. So that is one important thing, and that is why two different examiners are important for that, or a two different examining person. Now that is one thing. And the apex pulse deficit is usually appreciated when the heart rate is more, that is more than 90 or 100. Why? At a lower heart rate it is very difficult to get a apex pulse deficit. So if the patient has on a beta blocker, on a digoxin therapy, heart rate is 50 to 60, never comment on a apex pulse deficit, because examiner may ask you, and it is very difficult at that time that you may get a more than 10 difference. Second is, in a atrial fibrillation the A wave is absent as compared to VPCs where a wave is preserved. Third is a ventricular premature contraction, it goes off with exercise. So exercise decreases the VPC, it doesn't make any effect on atrial fibrillation. So these are few questions which they may ask you in exam to differentiate a VPC from a apex pulse deficit. So irregular pulse, I already told you, AF produces irregular. VPC produces a regularly irregular. Multifocal atrial tachycardia, flutter with varying block, and AF all produces irregular, but a VPC usually produces a regularly irregular pulse. And also a sinus arrhythmia, which is the cause of a irregular pulse. Again, I discussed irregular pulse, fibrillation, flutter with varying block, and sometimes atrial tachycardia with varying block. Multifocal atrial tachycardia, and rarely AF with WBW. We should not be get into this because it's a different thing only. So for clinical purposes, remember the first four causes, which is more than enough. Now, cause of a rapid regular pulses, all the sinus tachycardia, inappropriate sinus tachycardia, or a supraventricular tachycardia, or a junctional tachycardia, flutter with fixed block, and atrial tachycardia with fixed block. They are all the causes of a rapid regular pulse. So you should not have confusion on a regular pulse. It is more the irregular pulse which creates a confusion. Now, what are the causes of bradycardia? I already discussed. Cardiac causes are sinus bradycardia, first degree, second degree, third degree heart block, or high grade AV block. So these are the important cause of a cardiac cause of a bradycardia. Non-cardiac cause, there is a relatively bradycardia in typhoid fever or the hemorrhagic fevers like a dengue and all. Third important non-cardiac cause is obstructive jaundice, which causes bradycardia because of the bile salt. So bile salt have vagotonic effect, which causes a bradycardia. So these are the different causes apart from hypothermia, hypothyroidism and all, which also causes bradycardia. So these are the various causes of bradycardia. Now I already discussed what are the difference between a PVC and a AF. Now unequal pulses in the upper and lower limb is something which is important, because if you are able to feel the pulse in the upper limb, not able to feel in the lower limbs, means one, either there is a coarctation of aorta, or there is a obstructive disease of the aorta, let it be the atherosclerosis, or let it be a dissection. So many a times a patient, young fellow comes with you with chest pain, severe chest pain, back pain, you are not able to feel the pulses in the lower limb, but the upper limb pulsation is there. The diagnosis is dissection of the aorta. Young female comes to you with a pulse in the upper limb, no pulses in the lower limb, or there is a discrepancy in upper limb and right upper limb and left upper limb pulses, then you should think of autoarteritis. Old age, if upper and lower limb pulse are different, always think of atherosclerosis in the abdominal aorta, femoral arteries and all, and some rarely a trauma. So these are the causes of unequal upper and lower limb pulses. Now, unequal carotid, though not very common encountered, you should always think of autoarteritis, dissection of the aorta, atherosclerosis, or a thromboembolic occlusion, or a supravalvular AS. There is something known as a Quanda effect, where in supravalvular AS, the selective streaming into the right innominate artery. So the right innominate artery has more pulsation compared to the left. So that is known as a Quanda effect. Now, when do you get unequal radial? So the discrepancy in the pulse of right and the left, you get in autoarteritis, or a dissection of the aorta, or a thromboembolic obstruction. Sometimes you get a mitral stenosis and thrombus go to the left hand, or any LV clot which goes to the left hand, or a cervical limb. Or sometimes if you have a catheterization in the right through the right hand, you may not get a pulse in the right hand at a later date. Or rarely anomalous subclavian artery, right side or aberrant course of right radial artery, and arteritis. So these are the various causes of unequal radial between a right and the left side. When do you get absent femoral? I already discussed dissection, coarctation, and rarely the causes like pseudoxanthoma elasticum and a hypoplastic external iliac artery. Now, I would like to conclude by saying that few important points. If the arterial pulse is regular in a patient with AF, so if you have a already documented patient with AF who had irregular pulse and suddenly it becomes regular, you should always think that either there is a digitalis toxicity or the patient has developed underlying complete heart block. Also, a presence of a dicrotic wave suggests a bad prognosis. Why? Because either you have a hypotensive patient, septic shock patient, and the patient. So that is what a dicrotic pulse is always a grave prognosis. Severe MR with good LV results in normal volume pulse. That is a mini collapsing pulse. And electrical alternance has no relationship with the pulseless alternance.